We are fortunate to have a very distinguished guest with us today, Dr. Keith Aronson, whom Dr. Fuster will introduce formally a little bit later. We are also lucky to have a very distinguished panel. Moderating our panel today will be Dr. Sean Pinney, Director of Heart Failure and Transplantation for the Mount Sinai Health System.
Thank you, Eddie. Thank you, Dr. Pinney, Dr. Aronson, for the fantastic talk you gave us earlier today, Dr. Goldman, though you can't be with us, and Dr. Fuster. Heart failure is an important public health problem with a high burden of cost, morbidity, and mortality. The current global prevalence of left ventricular systolic dysfunction is estimated at 5% for patients with advanced heart failure. For these patients, treatment was limited to heart transplantation until the development of the LVAD. Today's topic is a special one for me personally. Growing up in Shreveport, Louisiana, my mother was the head scrub nurse who helped establish their first heart transplant team. As a part of this team, she assisted in implanting the first biventricular assist device. Highlighting how much technology can evolve, during that operation, she had to break sterility to autoclave the instruction booklet for implantation that had fallen on the ground when the patient went on cardiopulmonary bypass. Such as with any new technology, there's a learning curve during which technology evolves and the outcomes of patients inevitably improve. Over the last several decades, we've seen indications for mechanical circulatory support expand beyond its initial use as support for patients post-cardiotomy to now devices being used predominantly as a bridge to transplant, bridge to recovery, or destination therapy. Today, we will discuss the benefits and risks of LVAD implantation and discuss potential merits of LVAD implantation in selected patients before they become dependent on inotropic therapies. LVADs have and continue to evolve. First-generation devices create pulsatile flow and improved survival compared with medical therapy in patients awaiting transplant and when used as destination therapy. Second-generation LVADs were developed to be smaller, more durable devices and provide continuous flow. Clinical trials validated these devices as efficacious when used as a bridge to transplant. In patients selected for destination therapy who were randomized to second-generation versus first-generation devices, second-generation devices improved survival, and notably both devices improved quality of life and functional status. Newer third-generation devices sit in the pericardium, use centrifugal flow, and have bearing lift systems to minimize the amount of moving parts. Preliminary data for these devices and data from Dr. Aronson continue to show improvement over first and second generation devices. The Centers for Medicare and Medicaid Services mandate that for patients to receive a destination therapy LVAD, they must have an LVEF less than 25%, advanced heart failure for 45 out of the last 60 days, a peak oxygen consumption of less than 14 cc's per kg per minute, or inotrope dependency and be deemed ineligible for transplantation. That said, current indications for bridge to transplant LVAD implantation are vague, and clinicians attempt to balance the risk of dying on the transplant list against the risk of death related to LVAD implantation or complications. Typically in practice, clinicians use the inclusion criteria of the critically ill population from destination therapy trials and from the 7-category INTERMACS classification scheme to assist in selecting patients for implantation. The first 3 INTERMACS classifications consist of the sickest patients, all of whom are inotrope dependent, and is in this patient population that LVADs have been used the most frequently. Interestingly, the most recent report of the INTERMACS data reveals that less patients in INTERMACS Class 1, the sickest of patients, are undergoing LVAD implantation, and that more and more patients in INTERMACS 3 and 4 are undergoing device implantation. This could be as patients become more critically ill, they develop concomitant right ventricular dysfunction, renal failure, and hepatic failure, all of which are associated with worsened post-implantation outcomes. Survival data among second and third generation device implantation in this evolving cohort continues to be favorable, with 1-year survival of 80% and a 2-year survival estimated at 70%. Few trials have evaluated the use of LVADs in less critically ill patient populations. In small observational studies, patients who have undergone implantation classified as INTERMACS 4 through 7 have significantly improved survival compared to INTERMACS 1. And the most recent INTERMACS report notes that Class 1 patients had significantly worse one-year survival than other classifications. Recently, the landmark ROADMAP study observed non-inotrope-dependent ambulatory heart failure patients who underwent LVAD implantation had improved actuarial 2-year survival, similar intention to treat survival, and greatly improved functional status and healthcare-related quality of life. Despite these favorable preliminary data, LVAD implantation in less sick patients is controversial. And as the rates of adverse events associated with implantation, namely infection, right ventricular failure, pump thrombosis, and stroke, are present, they are not negligible. This makes for fertile ground to debate the potential benefits of expanding the patient population selected for LVAD implantation, which we will attempt to do during this panel discussion today. Thank you for your attention.
Thank you very much, Andrew, for your excellent presentation. I didn't have a chance to read your manuscript, but I'm sure it's as excellent as one can see. It's a pleasure to introduce today Dr. Keith Aronson. You know, and one thing about the University of Michigan, there are so many good people that have evolved over the years from that university, and Keith is one of them. So let me say a few words of introduction to him. From Johns Hopkins and college, he attended medical school at Baylor College of Medicine. And then he went to Michigan, where he had his internship in medicine, residency in medicine, and then his fellowship in cardiology. It was in 1993 when he moved to New York as assistant professor of medicine at Columbia University. And at that time, he worked, at least was probably his initiation in the transplantation field. It was in 1996 when he went back to Michigan as assistant professor of internal medicine, associate professor, and eventually professor of medicine. I would say that in terms of the academic positions at the present time, he carries the name of a great person, Bertram Pitt, and he's the Bertram Pitt Collegiate Professor of Cardiovascular Medicine, Medical Director of Heart Transplant Program, and Medical Director of the Center for Circulation Support at the University of Michigan. Now, he has a remarkable career in terms of a recipient of numerous grants from the federal government and from industry. He has had 39 grants, actually. And he has been also in the study section of NIH, and he's in the editorial board of a number of journals, and certainly in JACC. I'd just like to say that he has been very prolific in terms of the literature. And what is interesting about him is he obviously has more than 100 papers, but it's the quality of the papers that he has been involved. And I went over today just to refresh my memory because I know of him, but it's fascinating. He has been in the forefront of a number of issues related to heart failure, starting from pharmacology. Then he moved into devices, and certainly one of them is LVAD, if you call this a device, and certainly in transplantation. And what is beautiful about is that he has a number of papers in which you can see the interaction of the three aspects, the pharmacological one, the device one, and the transplantation one. So I think we have with us a very knowledgeable individual, an individual of high quality, and it's a pleasure to give you this plaque, Keith, just for you to remember your visit here today, which comes from our faculty expressing you the appreciation for outstanding teaching expertise to, I don't know if Dr. Sharma is here today. He was with me actually yesterday in India, and I don't think some reached the airport of Kennedy today, some didn't. It was not easy. And then the Simon Dack Memorial Lecture. So I really appreciate your visit today, and I know the fellows are enjoying it very much.
Thank you so very much.
Which is a pleasure. So now you are going to occupy the center seat. And then, well, all your colleagues of ours who are going to be part of the panel were already mentioned before. You can come in, I guess, just Dr. Vitri, Gopalan, Donna Mancini, who was in India also, and she arrived this morning. And Mark Miller, my friend Mark Miller is here, so see if you push him today. And Amit Pawar, which is coming, also representing the cardiothoracic surgical group. Okay, so, and Dr. Penny, of course, who is going to be the leader of this panel.
Great, thank you very much, Dr. Fuster. So it's good to have both you and Dr. Mancini back safe and sound after traveling back from Mumbai yesterday. It's also a great pleasure to spend a little bit of time with Keith, who is a friend and a role model for someone like me who likes to practice in those areas of heart failure, LVAD, and transplantation. And for those of you who may not know, Dr. Aronson and Dr. Mancini are really two pioneers in the field of heart failure, and all of us who take care of heart transplant patients and advanced heart failure patients owe them a debt of gratitude for shining the light and providing us the way to know when to select patients for advanced therapies such as VAD and transplant. We'll talk a little bit more about that in a few minutes. So I just want to start off very broadly and touch upon a few themes within the field, talk a little bit in some detail about patient selection, and then maybe get into some more of the nittier, grittier aspects of ventricular assist device therapy, which are controversial within the field right now and hold a lot of interest for those of us who immerse ourselves in this 24/7. So I went to the INTERMACS website. For those of you who don't know what INTERMACS is, Mark, INTERMACS is a national database, and everyone who receives a ventricular assist device is encouraged to report to INTERMACS. In order to have certification from the Joint Commission to implant ventricular assist devices for destination therapy, we have to report to INTERMACS. So INTERMACS started 10 years ago, and in that time they have opened up to 172 implanting sites. They have almost 18,000 patients now who have received mechanical circulatory support devices, which if you reflect back 10 years or 15 years, the idea that there'd be 18,000 patients who have received a left ventricular assist device is really quite remarkable. So it's rare in medicine to witness multiple revolutions. We're in the midst of one right now in the field of advanced heart failure as we see heart transplantation and mechanical circulatory support devices vie for attention. So with that sort of as prologue, Keith, let me ask you, what excites you about the field of mechanical circulatory support? What is it that grips you about this field?
You know, I think in heart failure, thank you. In heart failure, we certainly can do a lot with just standard of care that really every internist, family physician can do, but there are still a substantial, it's a minority of patients, but a substantial number of patients where we get to a point where it seems in the absence of these therapies, the game would be over. And there is this ability to, at least for a while, cheat death with these devices, and that's a kind of a heady thing. And with our surgical colleagues, we can really make enormous improvements in folks' lives. But these are, you know, as Andrew and you alluded to, these are really they're powerful two-edged swords, and it's clearly very important that everybody gets into it with their eyes wide open, recognizing what the potential advantages are and what the risks are. And I think if they do so, then they can face the challenges in a much better way.
So Radha, you like me, we've sort of seen the transformation from pulsatile devices to continuous flow devices. Tell me a little bit more about that story. Tell me a little bit more about what the outcomes are like with the pulsatile devices. Tell me what the outcomes are like with the continuous flow devices. Why is this so revolutionary?
With the pulsatile devices, when we started implanting those devices in the late 90s to early 2000s, one of the problems is, one, they were bulky, and we started with extracorporeal, and then started implanting intracorporeally. As that progressed, one of the issues were devices not lasting long enough for patients who needed it long enough to have the transplantation, as well as complications with the pulsatile devices, with bleeding, pain, and infectious complications. What we have seen now with the new generation devices is longevity of the device is tremendously improved, and patient comfort is significantly improved, and they're able to do much better, enjoy much better quality of life, simply because almost all the devices now we implant is intracorporeal. And they are able to, so much so that we have patients who can go and even engage in recreational activities such as playing golf and enjoying what they used to do.
Yeah, there's a group out in San Diego who is sort of renowned for implanting in older individuals. We'll talk about that too, but it's a great slide where they have 3 individuals. I think one is 88, the other's 90, the other's 91, at the first tee of the golf course with their devices getting ready to tee off. So it's a great promotion for being able to save lives, as you mentioned. Donna, let me turn to you. I mean, we heard a little bit about the potential of what this device offers. It's life-saving, life-extending, life-improving, but not without cost. So on the flip side of the coin, what irks you about this field? What is it that is bothersome or leaves a lot of potential problems in the way?
I believe that LVADs have been a huge advance in terms of bridging patients to transplant. But I think for long-term therapy, I'm a perfectionist, and I like things to run really well. And LVADs have lots of major problems. I think the high readmission rates for stroke and GI bleeding and pump thrombosis are unacceptable. And I can deal with it if it's a short-term device, or if it's someone who's inotrope dependent and really has no choice. But to start to push the envelope back and put it in less sick patients, I have a problem with that. And I have to say that I like Andrew's presentation, but the roadmap study is not a landmark study. It's an observational study. And someone who tends to see the glass half empty, I would just say that basically what that study showed to me was that I can delay implantation of the LVAD safely in patients who have class 3B heart failure.
So I think that's a perfect segue to the next topic, which is that when you're trying to decide when to implant one of these devices, it's a balancing of risks and benefits. And we certainly have the benefits which are offered by the device, the risks that we're going to talk a little bit more about. But you really need to know what is the competing outcome. What is going to happen to that individual if you don't implant a device, or if you don't do a transplant, or if you maintain them on inotropes, which really gets to risk prediction models. And there are no 2 better people in the United States right now to talk about risk prediction models than Dr. Aronson and Dr. Mancini. But let me start off with the glass half empty and say, Keith, why are we so bad at predicting outcomes in patients with heart failure?
Because life isn't deterministic. We're trying to predict a biological phenomenon with very, very imperfect information. And I think it's a really interesting question as to, what if the area under the receiver operating characteristic curves for our best models in heart failure is about 0.75 or so. So, we're half better than a coin flip, I guess. What's the upper limit on that? And it may not be that much higher, right? Depending upon how big a time window you give yourself. Certainly, as you know, with the Revival Registry, we're trying to get a better grasp on predictions of survival in this population. But it may be a task that we can, I think, we'll always approach it, but I don't know that I don't believe we'll ever actually get there. But I suspect we can do better. Heart failure is hard, right? Because it's not like an anterior wall MI where you look at the EKG and you get some image and you know what you have and how much you have and what the damage was. Ejection fraction is a very imperfect measure, and we know that the association between ejection fraction and peak VO2, for example, in VF1 and VF2 that was looked at in the R squared, I think it was 0.09 and 0.16 in the two studies. I mean, it's almost a scatter plot. While we certainly know a lot more than we did when Donna really started all this work, there's a lot we don't know, and that makes it hard.
So Ray, if you could give some advice to our colleagues out in the audience. So they manage a lot of patients with heart failure. They're very good at establishing and increasing neurohormonal antagonists. How do you know when someone is approaching the need for advanced therapies? What sort of things do you look for clinically? And can you tell us a little bit about the risk prediction models like the heart failure survival score, recognizing that the two people who created it are on your left?
So, I mean, I think the first thing to say in terms of evaluating a patient to say, are they at that advanced level, are they stage D heart failure, is first seeing what room there is for additional medical therapy. So as you've just outlined, you have to take a very sober look to say, have you really optimized their medical therapy at this point? Have you maximized their doses of neurohormonal antagonists? Have you assessed them for cardiac resynchronization therapy? Have you done all the things that they can possibly do, treating obstructive sleep apnea, managing obesity, risk factors, everything, and really take the time to really thoroughly examine to say what room is there for medical therapy? And that has to be the baseline and obviously any reversible cardiac condition needs to be considered. Immediately what comes to mind is when you start to identify that patient that's at high risk of decompensation is those who you are having limits in advancement of neurohormonal blockade, who are having cardiorenal, hypotensive, any sort of limitation to advancement of their neurohormonal blockade. So the patient that you no longer have on a beta blocker because they're too sick for a beta blocker, the patient who you can't have on more than 2.5 milligrams of lisinopril. Those patients are, I think, immediately you have to put them in a separate category at that point, because not only is that predictive of knowing that of increased risk in the future, but you know that they're somebody that you can't treat. If you can't put them on these medicines, what are you treating? You're just allowing the natural course of the disease to progress independently. From there, there's various individual markers of hypotension, worsening renal failure, as well as sort of putting all those together in various risk scores. I think for me, it's obviously a slam dunk for us whenever we assess a patient, we find them on inotrope or inotropic dependent. Anybody that is not inotropic dependent, it ultimately becomes gray and it's difficult to assess. But I think to me what ultimately has to drive that decision to move forward is when you really feel like you're unable to treat, you've maximized medical therapy and you're unable to help that patient and they're showing limitations of those therapies.
So Rod, I'm looking out in the audience and I'm seeing colleagues who I said, I wish you had sent this patient to me sooner. What specific indication would you say to someone to say, hey, look, if you meet criteria 1, 2, 3, 4, I want to see that patient in the heart failure center, because to me that signals a patient who's in trouble. And I think Ray did a great job describing those cardiorenal limitations to prescribing or advancing neurohormonal antagonists. What other concrete recommendations can we provide to the audience?
I think when you're involved in treating a heart failure patient, I just want to point out one other thing, and that Keith mentioned, it is a syndrome. So that's one of the reasons why we have trouble predicting who is going to be at higher mortality and who is not, because it's a combination of several factors that come into play. It's just because the disease is a syndrome, it's not a slam dunk like a myocardial infarction where you can take a look at it. So throughout the entire practice of managing a patient with heart failure, one has to continue to ask, am I making a difference in the progression of the disease? Not only just how the patient is feeling and functioning, but am I making progress with the internal milieu? So you can assess it by BNP levels of rehospitalizations and recurrent hospitalizations and decompensations, end-organ dysfunctions, and all those parameters will help you decide how that goes. But is this patient progressing to advanced heart failure? I think that's a trigger. Now, for many years, we have not had a good understanding of what constitutes advanced heart failure. And I think one of the things that we are going to talk about is about less advanced heart failure. But fortunately now, the European Society has put out some degree of clarity for a working parameters that you can use, which has been later adapted by ACC/AHA, and what constitutes advanced heart failure. And I think as a physician treating heart failure, what I decide is when I want to escalate therapy is when a patient meets the criteria for advanced heart failure. So if someone has an ejection fraction that is less than 35%, has had hospitalizations, and their 6-minute walk distance is less than 300 meters, or their NYHA class is declining despite maximal therapy, and this is in the setting of having instituted maximally tolerated neurohumoral antagonist medications or optimal medical management. If those criteria are being met, it is about time to think that I have exhausted my abilities and it's time to think about a disease management program and perhaps an early escalation to the next level of therapy.
You know, let me turn to you, Keith. When I look at the components of the heart failure survival score, there's a lot of information in there. There are a lot of very strong univariate predictors of outcome. Can you talk about the individual components that's embedded in there and what clinicians should kind of pay attention to as risk predictors and how you incorporated that in your model?
Let me do that, and then I want to say something that has absolutely nothing to do with the heart failure survival score or individual predictors. So peak VO2 is a very powerful predictor, probably by itself, of the things in there the most. And in truth, there are other exercise parameters that are not part of it that may be even more important, VCO2 in some settings, oxygen kinetics, uptake kinetics. But peak VO2, I think, has stood the test of time. It does give us a sense of whether somebody has done put a maximal effort forth or not. 6-minute walk clearly has predictive ability, but if one doesn't know for sure whether or not the person has really made an effort and you'd like to have something a little more objective. Some years ago, we looked at how well 6-minute walk correlated with peak VO2, and it turns out that if people on their cardiopulmonary exercise test had an RER of 1.1 or higher, there was a very tight correlation. But folks who didn't, who had a submaximal effort, not surprisingly, it correlated quite poorly. I think serum sodium is one of the strongest predictors in the model. Interesting in context of our conversation earlier today in terms of sodium restriction and free water uptake. Blood pressure, we ended up using the mean blood pressure. That was statistically, that actually was the strongest of the different blood pressure parameters, but that probably was foolish of us. It requires a little more math than people like to do. Heart rate, of course, really is probably in the modern era is not as useful as it was before. Obviously, the model was developed prior to the widespread use. Obviously, beta blockers were alive but before, or around, but it was before the widespread use of beta blockers, and papers that we and others have written since then showed that while the model continues to discriminate, the calibration is off because of beta blockers. Interestingly, one of the strongest predictors was whether people had a wide QRS complex or not. And it's just kind of funny because, when we did the analysis, it didn't really matter whether they were paced or whether they had a native, conduction delay. The hazard ratio associated with it was about 1.7 to 2. And had we been smarter, we probably would have maybe moved forward the development of cardiac resynchronization therapy a little bit more to realize what a bad thing pacing is, or univentricular pacing is. But we weren't that smart. What did I miss?
Etiology.
Etiology of heart failure, right? So ischemics do it's about twice as bad as non-ischemics. I think that's all important. But I think, and I'll put in a plug for Wayne Levy, because if he was here, he surely would have put in a plug for the Seattle Heart Failure Model. But certainly that has some advantages, and that it doesn't require exercise testing, although I think exercise testing has other advantages in terms of feeling good about your risk prediction. But I will say to you that when I'm thinking about a VAD, beyond those more objective measures of what's this person's limitations and what's the prognosis, I really want to know that that one, they have a realistic understanding of what a VAD is and what it might give them, and both pro and con. But I also want to know that they feel bad, that they really they feel that the quality of life that they have from their heart failure is really poor. Because kind of like, treatments with, percutaneous interventions or bypass surgery, or even, some drugs in people who who don't have angina, you can't, if it's not broke, you can't fix it. And as Donna mentioned, the roadmap study really clearly shows that there is no treatment imperative for people who have class 3B, whatever that is, heart failure. The intention to treat, survival was the same in both groups. So what is there any other messages from that study? And I think the message is that the folks who got the VAD felt bad beforehand and felt better afterwards. Now it's been pointed out that they all know they had a VAD, and is that a placebo effect, as it were? And I guess I would say that if you can put up with a drive line and not showering, or showering with saran wrap, rapid saran wrap, and the 30% odd or so people get GI bleeds, and the 10% who get strokes each year, and all the rest. And at the end, the group as a whole tends to, rank their, health utility as more than double where it started. That's a pretty good placebo effect, and I wish I could put it in a pill and give it to other people too. But I think that only works if, in fact, they feel lousy. And I think it's really important. I think all of us have had the experience of transplanting somebody who, got transplanted for, had maybe VT that was refractory for some period of time, and were, begged to do it, but they didn't suffer enough. And then they get transplanted, and they're not happy at all. And I think if you're not happy in a transplant, you certainly won't be happy with a VAD.
I think those are great points. I also thought that you were going to go a different direction too. I'm thinking of Dr. Shumway's comments, like, show me a patient who does well after transplant, and I'll show you someone who didn't need a transplant. And I think that's certainly relevant too with ventricular assist devices. And we want to achieve two goals with the device. One is that we clearly want to make people feel better, but we also want to extend survival. So let's move on and say that we have identified a group of patients who've made that transition from stage C heart failure to stage D heart failure. They've progressed to advanced heart failure. Knowing when to put in a ventricular assist device is critical The majority of devices still in the United States are implanted when patients are either in critical cardiogenic shock or bordering on cardiogenic shock. And since it's important to understand when someone is less sick or more sick, Andy, can you just walk us through, you mentioned the Intermax levels. Can you just walk us through one more time, what are the different Intermax levels? How does one qualify for each one of those 7 levels?
Yeah, so the Intermax classification scheme is really a 7 sub-segment scheme that looks at patients who really, I think the 7th is the healthiest of the group, are NYHA class 3B heart failure. And the 7 different divisions are really the sickest of the sick and dividing those even further. And so an Intermax class 1 would be the classic patient who we have on call in the CCU who had a massive MI, who's coming in, who's having rapid initiation of inotropic therapies, and then rapid initiation of vasopressors to maintain their blood pressure still with a low cardiac index, and then either gets placed onto a temporary mechanical circulatory support device overnight, be it an Impeller or ECMO, and then goes to LVAD as what I think of as the critical cardiogenic shock. Counter to that would be someone who, Dr. Gopalan and I had a patient just like this in August, which is Intermax class 2, the sliding patient who is on inotropic therapies in the CCU, waiting around stable, but then over the next several days, you start to see slowly but surely the levels of medications required to maintain their cardiac index are going up. And this is opposed to Intermax class 3, which is where you're on a stable dose of inotropes and you're on the floor doing well, you're maintaining your cardiac index. And then 4 through 7 are really just differences in symptoms. So class 4 would be a patient who has symptoms at rest but doesn't require inotropic therapies, is maintaining their index. And then 5 through 7, less and less symptom limitation is the way that I visualize the Intermax classification scheme. I will say that whenever we're on call and admitting these patients to the CCU, it's never really on the forefront of our mind, where are they falling in the Intermax classification scheme? It's more of how can we help this patient to the best of our ability now? And then the decision for advanced therapies either comes emergently or in the more stable patient in the following several days. But overnight, it's really the class 1 patients who we're calling you about trying to figure out what to do next.
So just to put some numbers behind what Andy had said, about 45% of LVADs are put into those patients who are Intermax level 2, which means that they're sliding fast, they're going to the coronary care unit, they're unstable, and they require higher doses of inotropes, or maybe even needing to place a balloon pump in order to achieve stability. About 15% are implanted in those patients who are in clear-cut cardiogenic shock. Only about 25% are Intermax level 3. And I think for our program, we would say that's the sweet spot, where you have someone who is stable on an inotrope, preferably ambulatory, maybe even at home, but they have clearly identified themselves as being sick enough to benefit from the device, but not so sick that the risks of complications from surgery are amplified. Only about 10% are Intermax level 4. And as Andy said, these are patients who are just like NYHA class 4. They're symptomatic at rest. Intermax level 5, with any exertion, they become short of breath, and Intermax level 6, minimal exertion. So nowadays, the majority of pumps are put in for those patients who are at the higher Intermax levels, meaning that the post-implant outcomes are actually affected by how sick they are going in. But if we were to move this therapy into less sick patients, let me just ask the panelists what you would want to see before you would recommend this type of therapy to less sick patients. So let me start with you, Andy. You get the first. What do you want to see?
I think that I would want to see somebody who's so symptomatic that they would be willing to accept the risk of potentially 10% life-ending stroke. If you look at the patients who died in the most recent Intermax report, 50% of deaths, both early and late, were neurologic events. And so I'd want somebody able to make, or with a healthcare proxy, able to make the decision to be able to accept a substantial risk of potentially life-ending stroke at the cost of their symptoms.
So shared decision-making, they pull the trigger.
Yeah.
Okay. Mark?
You want me to comment on LVAD implant? No, at least from an EP perspective, I think the biggest issue that we always face is when the patient comes in with recurrent VT shocks, ventricular arrhythmias, is when to offer them an LVAD, if at all. And part of it is we just don't understand. We don't know why. We don't know which patients benefit from LVAD implant in this setting of ventricular arrhythmia storm, for example. Would be nice to know is to follow these patients over time and see which patients who actually, instead of getting an ablation, went straight to LVAD, ended up doing better. All of them will have some degree of ventricular arrhythmias, but I mean survival, versus the ones who we get a hold of first. We do an ablation and then we hand it off to you guys. Sometimes better, sometimes worse. So I don't think we quite understand that patient population at all.
Radha, what do you want to see before you would recommend an implant in a less sick person?
I think one of the things that has helped us is the granularity that the Intermax levels have given us in understanding these patients. And as Andy mentioned, if you're looking at Intermax 7, that's New York Functional Class 3. If you're looking at 6, that's 3B, and then the rest is 4. And the first 3 are inotrope dependent, and the other, the 4 and 5 are non-inotrope dependent. So that's how I look at it, and I look at the Intermax level in addition to the things. So this is the controversial issue. I mean, it's easy to decide offering device in 1, 2, and 3, and we have been moving back and forth between 1, 2, and 3. The question is 4, 5, 6, and 7. And I think 7 was a big question a few years ago when we as heart failure specialists, created the Revive It study and proposed a study to see if less sick patients can benefit. And it's on hold now because of the equipoise. The balance of forces is in question at this point. So that is on hold. As complementary came the roadmap trial, which has told us what we already somewhat know, which has confirmed what we know. As Dana mentioned, it just has told us that I can perhaps delay a little bit offering the device to patients who are less sick. So what do I need to have? So in my mind, what I tease out with regard to the Intermax level is that I look at the Intermax level and the functional class, but I also look at every Intermax level also has other comorbidities associated with it. For example, if you take an Intermax level 5 patient, if the patient has diabetes, it adds another layer of increased mortality. If the patient has obesity, it adds another layer. So would I recommend LVAD to a patient who is at Intermax level 5? Would I readily recommend who is not obese, who doesn't have diabetes, who doesn't have significant renal function? If you look at the roadmap trial, the highest creatinine is about 1.8. So would I recommend to someone who doesn't have those comorbidities? Perhaps not. But would I have a low threshold to recommend a device to someone who is diabetic, who has significant renal dysfunction or accelerated decline in renal function despite medical therapy? At the same Intermax level, I might be more inclined to recommend the device. And that's the way I will tease out in my practice how to offer the devices to these less sick people.
So to synthesize that down a little bit, and correct me if I don't classify it correctly, looking for a patient who doesn't have a lot of comorbidities, where the likelihood of a successful implant is much higher, would consider that if they were less sick, higher Intermax level.
Correct.
Donna, what do you want to see changed in order to move this field forward?
Well, I really think that at this point in time, it's pretty easy. If someone is dependent on a stable dose of inotropes, those patients are bad candidates. And the only less sick patients that I would consider are patients who, for some reason, can't tolerate inotropes. And what I need a new device. I need a device that doesn't cause acquired von Willebrand's disease and doesn't cause thrombosis and hemorrhagic strokes. I want a device that doesn't have a drive line and has all those infections. I need a new device.
That's a lot to ask for.
Yes.
So no strokes, more biocompatible, no bleeding due to acquired von Willebrand's, fully implantable.
And I want a device that when they put the device in, I can actually exercise more, because the exercise performance of these device patients is atrocious.
So let me come back to that in a minute. Don't let me forget that. I want to talk about dumb pumps and smart pumps. So Keith, what do you want to see change? What do you think has to change before we can extend this to less sick patients?
Coming on the exercise?
Yeah.
Sorry. So a really neat study that was presented at the Utah conference that my ex-resident, Bill Cornwall, did, working with Ben Levine at UT Southwestern, where he showed for unselected, other than the fact that they were doing fine on the VAD, that in fact cardiac output improved hugely in patients on VADs, with only about 20% of the cardiac output, incremental cardiac output, coming from the pump. It's very interesting. It turns out that these people on long-term support, there's far more cardiac reserve than we've appreciated.
And how did they measure that?
What's that?
How did they measure it?
Directly.
They did
Yeah.
swans?
Yeah. What do I want? Well, of course, I want all the same things Don wants, but I want world peace too. I don't see it happening anytime soon. So until then, what do we do with what we have? So I will tell you that, so I come at this wanting really badly to do a randomized trial to answer the question and not being able to do that. It's been alluded to, but just for those who don't know about it, we had an NIH-sponsored randomized trial comparing medical therapy to VAD therapy, and we actually, my colleague Frank Pagani and I at the University of Michigan were co-PIs of the study with Bob Cornwall from Pittsburgh, and we stopped it because after the New England Journal article that many of you are aware of showing increased pump thrombus rate at Cleveland Clinic, Duke, and Barnes at WashU, and then subsequently the Intermax analysis showing that the rate was actually, at least nationally, only appeared to be mildly increased, recognizing that the Intermax data is not nearly as complete. We had 4 pump thrombosis in the course of a month and decided that we couldn't carry on with leading a study like that. I certainly recognize what the risks are on the other side. That said, I have been not swayed, but certainly influenced by the roadmap data, recognizing that it is not randomized and that the patients who chose to get a VAD are undoubtedly different from those, of those who didn't get a VAD, 10% or so were told they couldn't get a VAD, and 10% were told they were too well for a VAD, 10% or so were told they're too sick. And of the other ones, there's all those subtle messages that people get when you don't really think they're a VAD candidate that some of them might have gotten. And others just chose you didn't want one who may have a different outlook on life. But that said, when you look at the quality of life of those who were on the medical arm, it continued to decline. If you look at the quality of life of those who went on the VAD, it clearly was better. That's averaging in all those folks who had adverse outcomes. So the visual analog scale, with 100 being perfect, nirvana, and 0 being torture. People who get a VAD in the United States used to be at about 30, now they're at about 40. They end up at about 70. They end up a little bit higher if they're at the higher Intermax classes, the less sick, but not a whole lot different. The increment, the marginal improvement is less. But that's averaging the people who do great and the people who do terribly. So that's enormous. There's nothing that we do in medicine that comes anywhere close to that. I think that we probably should respect the well-informed patient. And by well-informed, I don't mean just that you had the talk with them, but they met patients. They watch more than the company videos, which are kind of Disney, but really made an intelligent, informed choice. But if they do that, I am, in the absence of being able to actually hold off to study it, I am willing to push hard, earlier than I was before, in people who I can convince myself know what they're getting into. What's gone unsaid here, but I think you alluded to it, Radha, is the obviously we also know something about who will do well beyond the standard comorbidities. I mean, we need to know about right ventricular function. We need to know, does this person have a history of GI bleeding? You know, if it's somebody who's already been on Coumadin and aspirin and it hasn't bled, you certainly feel better. I mean, they don't have acquired von Willebrand syndrome yet, but you know, those are important things to know about.
Sean, if I just comment on one thing is, one of the things, as you mentioned, about education and well-informed patient, if you look at the roadmap study, most of them haven't heard of LVAD, have not heard of LVAD.
Yeah.
And
right,
people who did
groups.
not hear about, yes, on both arms.
Right.
And one of the good things that the roadmap gave us is the questionnaire that was asked of the patients and the physicians about why you are choosing what arm you want to go to. That gives a lot of insight about what patients are thinking about and what kind of rationale they use to make a decision to go forward with the study or not go forward with the therapeutic intervention, not the study, therapeutic intervention. That's an interesting information that I thought in this observational study.
One thing that did bother me a bit was that, you know, they looked at the PHQ 8 or 9, a depression survey, and the people who got the VAD were, I think, at 13, the other ones were at 10, but they were significantly more depressed, the ones who got the VAD at baseline, which again goes along with being more, you know, unhappy with their state of life.
That's right.
And they improved, you know, significantly on that scale, which was good, but they were well into the moderate depression level, and one might question whether you should be making decisions of that magnitude when you're moderately depressed. Although it seemed like they, by and large, made the right decision for them.
So yeah, just to round that out. So in Roadmap, after the patients were given and their providers were given the choice, do you want an LVAD or not? And based on what they decided was the clinical course that they followed. And then after the fact, they asked, why did you make the decision? So of the ones that chose the LVAD, it is exactly what Dr. Aronson said. It was very, very, very poor health-related quality of life. Not that they were afraid they were going to die. They felt poorly and they wanted to do something. For the ones who chose not to receive an LVAD, even though their provider recommended it, there were two reasons why. The first was they didn't think they were that sick. They didn't think they needed one. And the second was that they didn't want to go through surgery and they didn't want to be encumbered by a device. So those are the things that frame our patients' decisions. It's not necessarily death. It's how am I going to feel? How am I going to act? How do I feel now? What am I going to feel like in the future? So let me move on, and Ray, in a minute, I'll give you a chance to talk about what you might want to see before we extend this to less sick patients. And you can include that in your other comments. But Amit, you've been very, very quiet, and I promise to ask you some cogent questions here. I think there's a theme that once you put the LVAD in, that the pump takes over. But the reality is that there are some residual liabilities. We have the native heart, which is a liability both in terms of right heart function, which we heard about before, a liability in terms of arrhythmias that we'll talk about in a few minutes, and liabilities with valvular heart disease. So Amit, just tell me what your thinking is about the liability of valvular heart disease, specifically the aortic valve, the tricuspid valve, the mitral valve. What's your approach to patients who have aortic insufficiency, tricuspid regurgitation, mitral insufficiency at the time of implantation? And are you leading the field or are you off on your own? It's a controversial area.
So, severe, moderate or severe tricuspid regurgitation at the time of implant, we tend to repair the tricuspid valve. Aortic valve, moderate insufficiency or more than moderate insufficiency, we repair the aortic valve at the time of implantation. And for mitral, it is slightly controversial whether to repair mitral valve because the usual concept is once you unload the left ventricle, there won't be mitral regurgitation. However, once patient exercise, maybe there is mitral regurgitation in spite of LVAD being there. Maybe they have more pulmonary vascular resistance and slower recovery. So in our institute, Dr. Anjan will repair the mitral valve for moderate or more than moderate mitral regurgitation.
Keith, what are you doing at Michigan? What do you do? I mean, I think most of us agree that we know that you have to address the aortic valve in the setting of more than mild aortic insufficiency.
Yeah, anything more than mild gets repaired.
What about the tricuspid? What about the mitral? Do you view them as liabilities?
Yeah,
Tricuspid, yes.
Tricuspid gets repaired. Even moderate would get repaired. We don't. Our surgeons don't touch the mitral usually.
I think we had a very illustrative case where we thought that we can always overpump the mitral regurgitation. If they have a lot of MR, you just turn up the pump speed, decompress the LV, there won't be enough blood volume to regurgitate. We learned the hard way that that's not always the case. And as Amit was alluding to, we had a patient who we couldn't overcome the degree of MR and developed severe pulmonary hypertension and really presented a rocky road and ultimately had to pursue a different mechanical support device. Mark, the idea that the heart is still there, it's still pumping, it still has a rhythm. We've noticed a couple things about the ventricular tachyarrhythmias after VAD implant. They certainly are very common. Are they associated with a higher risk of death, or are they associated with adverse outcomes? And what should we do about it?
So, about probably 30% of all people will have some form of sustained ventricular arrhythmias after LVAD implant. And we used to think, I think the majority of that was probably due to, or at least a significant majority was due to the cannula itself. And probably the more recent data is actually 90% are just related to the pure substrate. And then at this point, we have data, or there's recent data demonstrating that that having an ICD or not having an ICD actually does not impact mortality. And I know your group just recently submitted something which I thought was very interesting, because this question has been out there for a while: is do patients with LVADs actually need ICDs? I'm an electrophysiologist, so I say yes. But no, in reality, it seems to be, at least in the meta-analysis that you guys did, that there's a difference between the continuous flow devices and the pulsatile flow devices. And so you probably lose some degree of your benefit of the ICD in the newer generation devices. We do know that obviously patients who have sustained ventricular arrhythmias, that the RV can obviously fall apart if they're in for long periods of time. But I would say probably the vast majority of patients that we have that have had ventricular arrhythmias after the LVAD is in are more bothered by the therapies of the ICD than anything else. And so as of yet, for the moment, I think I don't think anyone really knows whether VF or VT post-LVAD has any true impact on mortality. It definitely results in readmissions and it results in quality of life issues, but I don't think anyone actually knows if it impacts mortality, and at least 2 papers demonstrate it probably doesn't.
Great, thanks, Mark. Mark's going to answer this question definitively in the review article that's due March 1st.
Yes, I'm sorry about that.
All right, so let me move on, and we'll wrap up with the last series of questions. So there are currently 2 devices which are commercially approved for patients who are being bridged to transplant. One is the HeartMate 2, which is manufactured by Thoratec, now St. Jude's, and the HeartWare HVAD, which is manufactured by Heartware. Approved for bridge to transplantation, not for destination therapy. The only device which is approved for destination therapy right now is the HeartMate 2. Keith, I can't let you escape without talking a little bit about the differences between these 2 pumps. And I'm asking this question not on my behalf, but on Andy's behalf, because Andy said he's very troubled by stroke. Endurance was, and is still ongoing, a trial of the Heartware HVAD for destination therapy. Results were presented at the ISHLT in France just a few months ago, last April. Still waiting to see the final manuscript to parse it out, but just want to make sure what I saw presented is accurate. 28% of patients had strokes with the HVAD. Is that accurate?
So I would love to answer that for you outside of here, but we aren't allowed to sign confidentiality things on that. That manuscript is circulating now and will be submitted very soon. I will just comment to say that I think it should have been circulated a year ago and submitted a year ago. So that's, I feel the same frustration over that you do.
So how often do you use hardware now?
So I will tell you this, because I could easily say our device. Our results with the HVAD are spectacular. We have.
So you're still using it at the same frequency?
We actually use it much more.
Okay.
Yeah. So institutionally, our results are outstanding with that pump, and much better than the results of the HeartMate 2.
No, I also like the hardware device. I haven't really seen the problems that some people, especially the Europeans, complain about.
What can I say? What is clear is that it was held up for a desire to collect data on the sintered pump with blood pressure control, and that clearly has made a substantial difference.
Can you comment as to whether or not those strokes were predominantly hemorrhagic or predominantly ischemic, thromboembolic?
Well, I mean, the issue is that the hemorrhagic strokes were much higher than expected, much higher than had been seen with the HeartMate 2, and then hemorrhagic strokes, are, if given a choice, not that you want either one, ischemic strokes are generally much more survivable. There does seem to be a relationship between control of blood pressure and development of stroke. It's for those of you who don't work in the field, but some will see, occasionally see a patient, and you see us augmenting antihypertensive therapy in someone whose Doppler blood pressure is, 88. It wasn't a mistake. We're not nuts. So we really do. We are very aggressive in trying to keep the mean arterial pressure between 70 and 80. I think that has been, at least the data would suggest that that's been, at least in part, responsible for the good outcomes we've had with that pump.
Can you tell me a little bit more about blood pressure control? Does controlling the blood pressure have any influence on ischemic stroke? Does it have any influence on hemorrhagic stroke? Why do you think it's critically important to lower the blood pressure, and why would you see such a signal emerge over what is really a very, very small or short time scale?
I'm losing you on the last question when you say why in the time scale.
Well, the development of a stroke, typically an ischemic stroke is within the first 3 months of implant, maybe out to 6 months or so, but it's pretty early on. Hemorrhagic strokes are usually very, very soon after surgery, within the first month or so. Why is it then that blood pressure control over the long term is so important? Isn't it really something in the short term and perioperative care that really drives the incidence of stroke, and not blood pressure control per se?
So, we're limited because the data haven't been collected over that long a period of time, right? But while there is the company, I think, fairly has distinguished between strokes that occur very early, where they're saying that's, operative, and those that are occurring later. And certainly you're right that there's a large group of strokes that occur within the first 3 months, but there's continuous strokes all the way out. But of course, the number of those, it's a smaller percentage of the whole, so it's hard to know. It'll take longer to know what impact we're having on those strokes. The incidence of both strokes appears to have come down. Both types of strokes appears to have come down on the device. I feel a little bit, I feel like I'm skating too close to what I really don't have the right to talk about at this point.
The hemorrhagic strokes that I've seen in patients with hardware have not been early in the course of the implantation. It's been far out. And I think part of the problem that I have with the blood pressure is I don't really know exactly how to measure
What it is, yeah.
Right.
So, interestingly, one of the companies that had been in the space, Terumo, was purchased by Thoratec, and they had a cuff that basically had a very slow. It was an auto cuff that had a very, very slow deflation. And while you would get error, not infrequently, if you had patients. If you had patients with a C, your patients with a T could do this at home and come back to us with numbers. And we did buy a whole bunch of them because that part of Terumo was based in Ann Arbor. But they left the pump business and were purchased by Thoratec. And I don't know if it's just a coincidence that their competitor had a blood pressure problem and wanted to have those sphygmomanometers, but they're no longer made. So it makes it difficult. Some work we did, Uli did when he was at Columbia with you, suggests that the difference between a Doppler opening pressure and a mean arterial pressure on an art line averaged about 8 millimeters of mercury or so, but there was a significant degree of heterogeneity. And when you're talking about, such a small, if the blood pressure is 85, maybe, 8 versus 12 or 13 is a huge difference.
No, I know.
So you're certainly right that it's concerning.
And it's also dependent on how much pulsatility there is.
Of course.
So if you have, pulsatility, then the mean blood pressure really is not reflective of what you should be targeting.
So we're essentially almost out of time, but I wanted to make an observation. And, Dr. Aronson said that they continue to implant the Heartware HVAD at Michigan, probably more so now than before, because their outcomes are excellent. I can share with you that we implant the HeartMate 2 almost exclusively. And during the time that there was a higher incidence of pump thrombosis, which was quite a maelstrom of controversy and publications and hand-wringing and things like that, where the incidence of pump thrombosis went from a historical 4% up to 8 or even 10%, our rate was 3 to 4% and has continued to remain at 3 to 4%, and we continue to implant the HeartMate 2. I think it underlies a really important observation, which is that as these devices, as these therapies begin to spread out to other centers, I think it's important to keep in mind that we're still dealing with a craft, that it is the delivery of care through highly experienced, highly specialized teams that is able to deliver excellent outcomes. And it's very difficult or very dangerous to generalize. So if one were to say, well, the Heartware HVAD is a terrible pump because almost a third of patients develop strokes, it glosses over the fact that there are some centers which deliver outstanding results with that pump. And the same thing, too, with the HeartMate 2. And maybe Donna, you first, and then Keith, you second, can comment on that, and then we'll wrap up for any questions from the audience. So, Donna?
I was a little jet-lagged on that. What were you saying?
So what I'm saying is that results vary from center to center, and that you really need teams develop very specialized experience.
Right. I think there are a couple of components. One is, I think the surgeon is important. I think the way the surgeon places the device and the angles that the inflow cannula and the outflow are placed, I think are very important. And then I think that the compulsiveness of the nurse practitioners maintaining the INR is very important.
Yeah, I mean, there's no question that this is so far away from being commodity at this point. The interplay of what goes on in the OR in terms of inspecting the heart, and all the nuances of care. I think it's hard to dissect that out for each center. You know what you do, and you keep trying to do better. But different centers do clearly have different experiences with the different devices that, to some extent, seem to be consistent. And I think it behooves you to do what you do well. But not surprisingly, in a field like this, what the surgeon does is tremendously important. I will say that we have had continued to have a high pump thrombus rate with the HeartMate 2, and we, as you may know, Sean, when we were hoping for the study to go on, we created a set of practice guidelines that have actually been incorporated by Thoratec in their study of anticoagulating, heparin starting right away, INR by day 4, never running the pumps below 9,000, and you can go through all of it. But we actually have 2 PharmDs who a large part of their job is just doing Coumadin adjustment for these patients. So there's a couple other groups they work with, but our time in the therapeutic range is in the mid-70s, which is, unheard of, even in AFib trials. Yet it hasn't made much of a difference, or maybe it would have been worse without that. Since you said we're close up, I just want to say first that what a thrill it's been to be here, and how incredibly touched I am by this honor. It's really overwhelming. Also to the young folks that I met earlier, I just say to you that your mentor is incredibly important. So spend some time and find a good one. And if you're really lucky, you'll get as good a one as I got. So.
Here. Fantastic. We can open up for a couple questions, and then we'll wrap up. Sandy?
Have you had experience with Entresto and Corlanor? You mentioned optimal medical therapy. That's part of it.
Experience with using Entresto?
Yeah.
Yeah. Fairly limited at this point, probably a dozen patients. Donna was just mentioning to me that she's seen some liver enzyme abnormalities. I haven't seen that yet. I have learned the magic words that you need to say to Blue Cross in Michigan to get it, which was sort of interesting. Turns out that you have to say that the patient has not, what was it? I can't remember the magic word.
You're symptomatic.
No, you just had to say they haven't met your goals of optimal medical therapy, your goals of therapy, some nonsense like that. I mean, it's kind of insane.
All right. If no further questions, I want to thank Dr. Aronson, our multiple panelists, Dr. Fuster, and the audience for staying late. Thank you very much.